And now we're continuing on my journey toward having 2 spinal fusion surgeries in 3 days. At the end of part 2, I've herniated a disc, and my rockstar neurosurgeon wanted to wait and see if it healed itself, as it often does. Meanwhile, it's back to physical therapy. Only this time, we're in the middle of COVID, and there's no way I'm going to go off and spend a bunch of time with a whole bunch of people in this room and then go home to my 71-year-old wife. So I went to my friend Google and I found ATI physical therapy. Now, what I did was distance physical therapy that they offered. And pretty soon I was one-on-one, face-to-face with Marin. Boy, what a difference this was than the physical therapy I had done for many, many times over many, many years. It was Marin and I face-to-face, and then I had a pad back here, and she would tell me what to do, and I would adjust the camera, and then I would go back here, and I would do my exercise, and she would watch me the whole time, and she would say, straighten your leg, arch your back, do this, do that. I mean, I just made me know how much I was missing when the person told me to do something and then left me. And the entire time, that's what we did, one-on-one. What a deal it was. Now, another thing that drove me crazy about the physical therapy I'd done before is at the end of each session, I would get this piece of paper with drawings on it. And the physical therapist would say, you need to do this and that and this and that. And you know what? Man, I never remembered all that stuff when I got home, and I'd look at this piece of paper and I'd say, how am I supposed to do this? I never knew if I was doing anything right. Well, Marin used an app, and it was terrific. The one she used is called PhysiTrack, and she would put in there a program of exercises for me to do. And then when I was ready each day to do the exercise she told me to do, I would have this to look at.
Lie on your back with your knees bent and your feet flat on the floor. Gently tilt your pelvis as if you're imprinting your lower back into the floor, and lift your hips up into the air while still holding your pelvis level.
What a difference that was. I mean, I want to tell you, whenever I wondered, am I doing this right? Then I would look at that video and I would be able to tell pretty good what I was supposed to be doing. I don't know why all physical therapists don't use one of these apps. They're not expensive. I subscribe to the app. It costs $14.95 a month, and I'm my only client because I put my own exercise programs together with it. But I've been to physical therapy in person since then, and they're still giving out those pieces of paper. I wish that would change. Now, another terrific thing that Marin did was she taught me how to use a TENS unit. She said, have you ever used a TENS unit? And, the only experience I told her about this, was after my first, the laminectomy, the neurosurgeon's practice that she was in had this physical therapist. One day he hooked me up to this. This one seemed like a big machine as my memory goes, but put these pads on me, and then all of a sudden it went, and then he said, walk. And does it hurt? And I said, yeah, it still hurts. And he said, well, I guess it didn't work. And that was the TENS experience I had that I relayed to Marin. Well, she told me about this deal. It's a little bitty thing. She recommended this. It's TENS 7000. One of her clients liked it. And looks like a transistor radio I had when I was in 1960. My first one, I was about 10. But these pads, you put these pads on there. Let me get it here. Put these pads on your skin, and then you turn it on, and it's just buzzing. It's really kind of a pleasant feeling. Sometimes it can sting, and sometimes, it's gotten loose and gotten in some very uncomfortable places, and boy, that wasn't fun. But most of the time, vast majority of the time, you just put it on, and it's amazing that when I have those pains down the leg that won't quit that I always went to the emergency room for, now I put the TENS unit on, and every time but one time so far, that has made the pain go away and hasn't come back. Now, it doesn't make the really sharp, bad pain while I was walking or sitting or anything, but the pain that wouldn't go away, that kind of stuff, it would. And now, to jump ahead a little bit and post-surgery stuff, post-spinal surgery stuff, I have left with that old backache that I used to have. And now I put the TENS unit. I wake up in the night with that backache on there, and I put the TENS unit on. Man, I go right back to sleep. You're not supposed to sleep with it on, but I do. It's just a yunk. So Marin, wow, what a deal that was. And the physical therapy I did later, which I'll talk to you about, I was able to manipulate so that I always had one-on-one physical therapy after that, even when it was in person. So now we're into early 2022, and I have what has become just mind-boggling, beyond the pale pain when standing or walking, and then even sitting. And by the middle of 2022, I couldn't sit at all. My neurosurgeon is once again saying, well, we need to wait and see what happens. I think that she got something in her head that affected her judgment. So for several months, I'd been taking 120 milligrams of oxycodone every day, 15 milligrams every 3 hours. And then my primary care physician just went cracker dog. And my life became bizarre and really, really hard and scary. Now it's early June 2022, and my primary care physician just goes off the rails. Now, it's crazy. This was all done by email. It's not he said. It's all on email, and I'm going to show you that, and you can draw your own conclusions from it. But before I show you those, I need to let you know about my relationship with my primary care physician, because it's not a typical doctor-patient relationship. He started treating me in January of 2003, but I knew him well before that. In the 1990s, our children were involved in an activity at the high school, and this activity involved parents standing around and waiting a lot. And so we kind of gravitated to each other and developed an acquaintance that way. And then after those activities went on for 3 years, and after that, I continued to have some interaction. One was, this is kind of weird, I would do my grocery shopping early on Sunday morning, and I would often run into my primary care physician and his wife at the grocery store. Now, they were dressed up to go to church, so I'm not sure why they were there, but we often stopped and chatted during that time. And then later, we were both involved in an activity where we got to know each other much better. Now, we still were never close friends, but we were more than acquaintances. So after that fiasco with my colonoscopy up in the attic with that primary care physician, I decided I needed a new one. And my primary care physician, who's the subject of this video, had a great reputation, but he wasn't taking new patients, but he did agree to take me. Now, when I became his primary care physician, he gave me his personal email address and his cell phone, and he told me to use it, and I did. And I want to show you some of those so you'll know the nature of what our relationship was up until 2022 in June. This is from my email program, just a search of my primary care physician. And you think, boy, you send a lot of emails to him. If you look at the dates, you can see it's just a few a year. Some years more than others, depending on what was going on. But I've just randomly taken a few of these. They're all the same. Here's one from, this was January 18, 2016. If you recall, I had a laminectomy in September of 2015. So I was about 5 months away from the laminectomy, and I had been tapering off the medication that I had been prescribed. The neurosurgeon had prescribed Oxycontin after the surgery, and the primary care physician was prescribing oxycodone as well. So in that second paragraph, I say, for accountability purposes, today I started my 3rd week of getting off the narcotics. I was taking 20 milligrams of Oxycontin a day and 5 milligrams of oxycodone twice a day. Today I started 10 milligrams of Oxycontin once a day and 5 milligrams of Oxycontin once a day. And then I described what the withdrawal symptoms are like. I just wanted to have accountability and let him know what I was doing with the narcotics. And at the top, his reply was, "Thanks for the progress report. Glad you are better." Oh, in the first paragraph of my email address, my email to him, I said that I had run into his wife, and she remembered who I was, and I was surprised. And so he says his wife has a great memory. And then he tells me and that he's having minimal pain. Then he says, "Not sure I would have the fortitude you have had." He's talking about handling pain. "Take care and keep up the good work." All right, this is September 15th, 2020, and I write, thanks for spending time with me today. I think of you often. In his reply, thank you, Ed. You're a good friend and father. We had talked about my daughter. Now, you might recall a year after the laminectomy, or a little over about a year and a half after the surgery itself, my pain returned. And so here I'm giving him a description. The neurosurgeon, had prescribed Lyrica, and I'm telling him what I'm doing with that, and then I'm trying to figure out how to sleep. So I'm just letting him know, because I always wanted to have accountability for the narcotics I was taking from the guy who prescribed it to me. So I'd let him know what was going on and tell him how I'm handling things. And at the bottom, his reply was, hello, Ed, your plan makes sense to me. Sorry you have not had a better recourse. And again, this is after the pain came back after the laminectomy, a couple of months later from the last one, and I talk about the way I'm handling this and telling him what dosages I'm taking and when and that kind of thing. And his reply to me, Ed, there is no reason that you cannot follow the regimen you suggest. Then he says, thank you for your honesty and accountability. Congratulations to my daughter Mariah and the family. She had graduated from George Washington University. Now here's one a little more personal. In an appointment I had with him, we got to talking about, for some reason, word processing programs, and he didn't have one or something, so I had an extra share available from my Microsoft Word program, so I said I would send him a link to that, and I did. And so here I'm saying, some time ago I sent a link to you to use to download you Microsoft Office. And so he wrote, got it, Ed, thank you. And then he says he saw my daughter today. And that was a random sample of emails. They were all just like that. Now, in March of 2022, after my first discectomy, my pain had gotten worse and worse, and he had increased my oxycodone until I was taking 120 milligrams a day. I was taking 15 milligrams every 3 hours, and I still had significant pain. So I went into an appointment that I had every 3 months, so he would write the prescriptions for oxycodone, one for that month, and then he would write a prescription for the next 2 months and have on the prescription, do not fill before this certain date. And so in that appointment, he said he wanted to add Valium, or diazepam is a generic name. That's an anti-anxiety drug that sometimes can help with pain. So he wanted to try that. Okay. So I went to the pharmacy and filled the prescription, and I got home, and I took the medication for a couple of months, and then I sent him an email. And in this email, I reported on how the trial had gone with the Valium. So I hate to do this, but I'm going to read this to you because this is critically important for you to understand what went on. I wrote, I have a prescription refill request. It is different than before. I mean, what he had prescribed before, and then an explanation follows. So the prescription request is a refill for Zolpidem that I was going to have pretty soon. And in this case, I said a half tablet before bedtime. And then I write, this is half of what was prescribed previously. In other words, he had said a whole tablet before bedtime. And then I tell him a suggested refill for a diazepam. And I write a half tablet before bedtime. Now, his original prescription had been a whole tablet. And I say a half tablet 2 times a day, and his original prescription had been 3 times a day. So I'm asking for refills of less than what he had originally prescribed. So I write beneath that, in our last appointment, you prescribed 10 milligrams of diazepam. You said to take 1 tablet at bedtime and 1 half tablet 3 times a day. That was on March 24th, and it was for 21 days. That was a couple of months ago, and I have 4 tablets left, so I've taken much less than prescribed. I've taken Zolpidem for several years in order to avoid taking more oxycodone. While it helps me fall asleep fairly quickly, at around 11 when I take it, I always wake up between 12:30 a.m. and 1 a.m. with significant lower back and leg pain. I use heat and ice to try to calm the pain until the next oxycodone dose at 3 a.m. Remember, I'm taking oxycodone 15 milligrams every 3 hours, so I might as well have been taking controlled release. It was in my system all the time. But that is a fitful sleep at best. Then I always wake up around 5 a.m. with lower back pain. I never feel very rested. When you gave me the diazepam, I took a whole tablet as directed instead of the Zolpidem at bedtime. When I got home that first night and I was directed prescribed to take Zolpidem and Valium, and that worried me a little bit to take both of them. So what I did the first night I describe here is that I didn't take the Zolpidem that night. I just took the whole Valium. And I said that really knocked me out, and I was fuzzy-headed for pretty much the whole next morning. I soon discovered that if I take half the Zolpidem, 5 milligrams, 1/2 hour before bedtime, and then take half of the diazepam or the Valium, 5 milligrams at bedtime, I go to sleep pretty quickly, and I wake up at 3 to urinate, take the 3 a.m. oxy, and then quickly go back to sleep and wake up between 7 and 8. I feel fully rested and refreshed. That combination has made a huge difference for me. Now then, the last paragraph, I wanted to, again, be totally upfront with everything that was going on with me regarding this medication. Now, something else had happened before I had the appointment where he prescribed the Valium. I had had a foot swell up, and he had sent me to a vascular center. One thing he mentioned to me was that it might be lymphedema. Well, I went to the Google School of Medicine to look up lymphedema, and that just was not good if it was that. It's not curable, and you have to have eventually wraps and all this stuff. And so I was looking at a whole nother thing to deal with. So what I write here is the diazepam or Valium has also helped during the day with dealing with this brand new issue of either chronic venous insufficiency or lymphedema. Since these medical issues began with the lower back arthritis pain at night, my long QT syndrome, which is something else that involves a heart electrical system, and I'm going to have a whole video on that at some point, severe stenosis and surgeries, etc., I really haven't had much anxiety. I'm saying I really wasn't anxious during all that stuff. But the potential of dealing with another situation that's going to require potentially more doctor visits, more therapies, etc., for the first time I find myself having some background anxiety. That is bothersome. Of course, I talk to John, my sponsor, and I attend virtual meetings, but the occasional dose of diazepam or Valium that you gave me has been really helpful. I feel absolutely no mood elevation. I just find I feel hungry again. I mean, anxiety when I have it, which has been rare since I had a change in life in 2002, I'm saying, I can eat again. I'm absolutely certain that this anxiety will end, but until then, it's been helpful to have the diazepam. However, if you think that's a bad idea, and I'm talking about taking it for anxiety and not just pain, then no problem. I won't take it. However, I really would like to continue the routine of splitting Zolpidem and the diazepam, as that has made a huge difference during my waking hours. So I just send this email reporting on the Valium trial that he had done for me. And we had not done any talk. We had no interaction. Nothing had happened between the time that he prescribed the Valium and between the time I sent this email. And here's his response. Now, you've seen his response to my other emails, and they were all like that. Here's this one. The diazepam, or Valium, was intended as a trial for the acute pain in the back for which doctor and the neurosurgeon did not have a remedy for. The Zolpidem is not due until June. I can give you a copy of PDMP. That's the state report on controlled substances, and Zolpidem or Ambien is like Schedule 5. It's the least likely to be abused, but it's still on the list. He says he can give me a copy of the PDMP showing 90 10 milligram tablets every 3 months. He's saying that it wasn't due for a refill yet until June. Well, I knew that. He had prescribed, as I said earlier, he was always writing prescriptions early for me. In fact, the prescription for Ambien that I had at the time that I sent my email that I needed a refill for, he had written early, and he had written, do not fill before this date. I was just trying to save time and not have to bother him again by telling him, hey, I'm going to need this refill. So then he has this comment in here as if I'm trying to get more Ambien than I'm supposed to have. And then he says, referring you to, and this is a really weird thing, this pain clinic I'd never heard of. Now, it turned out to be a brand new pain clinic in town, despite the fact there were all these well-established pain clinics. And in fact, I had been sent to one by my neurosurgeon to have those injections, and he knew I had already had a relationship with that pain clinic doctor. But instead of sending me to him, he referred me to this brand new pain clinic. Well, I was just astounded. I couldn't figure out what had happened. And man, I was really bothered about this implication here that I was trying to get the prescription earlier. I was misusing Ambien. So I had the bottle left where it showed that I'd only taken one a night. All you had to do is count the pills. So I wanted to take that to him and say, look, here's my Ambien. And I called to make an appointment. Well, what I was told was that he had gone home that day because he had tested positive for COVID. Well, I thought, okay, this explains it. He had COVID brain. It just did something to him because it was like, what was this? So I wasn't going to be able to talk to him for a while because he was sick with COVID, and I wanted to be compliant. So I made an appointment to go to this pain clinic. Well, when I went into that doctor, first thing I did was ask him if he knew my primary care physician. He said he didn't know anybody in Athens, that he drives over a couple of times a week from Atlanta, and he had just started doing that, so he didn't know anybody. So again, why did my primary care physician send me to somebody who he obviously didn't know? By that time, I had decided I just want to come off the oxycodone anyway. It didn't seem like it was helping me much. I thought I'm probably just tolerant and it's not helping. All it's doing is keeping me from going into withdrawals. And so I wanted to taper off it. I wanted to get down to a baseline where I knew what my pain really was for sure. So I told the doctor at the new pain clinic that's what I wanted to do. Well, he gave me this 30-minute lecture on the DEA and its rules, and I didn't know what he was talking about. Why are you telling me all this? I realized later that he was telling me that he couldn't help me taper because that would draw attention to him from the DEA, and he didn't want to do that. Again, this is the war on pain patients that is caused by the thoughtless war on opioids. But instead, he said he wanted to give me a Butrans patch for the pain. Now, this turned out to be something that was very, very disturbing. A Butrans patch is something you put on your skin that has the medicine buprenorphine in it, and it seeps the buprenorphine into your system. Buprenorphine is an opioid, like oxycodone, only it acts differently. Buprenorphine is very aggressive in taking up all the opioid receptors, so that if you have buprenorphine in your system and you take oxycodone, you don't get high from that because the oxycodone doesn't have any receptors to hook onto. And the thing about buprenorphine is, while it's an opioid, it has a ceiling effect so that you don't get high with it, or at least very high, not very high at all. It can be abused, apparently, but you have to work hard to do it. So while it doesn't get you high, it's used for pain, but it's not real effective for pain. Not as effective as oxycodone, obviously, because if you could give an opioid that doesn't give you high and it's effective as oxycodone, why would you get oxycodone every single time you have surgery? Pretty much, anyway. I mean, obviously, buprenorphine doesn't work for pain the way oxycodone does. But anyway, he was going to put this patch on me. And so I said, okay, I wanted to be compliant. So I went to the pharmacy and got it. But I don't take any medication just without checking it out. So I read the insert that comes with it with all the very fine print. And I went to the Dr. Google and researched buprenorphine. And what I found out was almost terrifying. The first thing is, and this is in the information that came with the medicine itself, it says taper the patient's current around-the-clock opioids for up to 7 days to no more than 30 milligrams of morphine or equivalent per day before beginning treatment with Butrans. Okay, I'm supposed to be on the equivalent of 30 milligrams before I even put this patch on me. Well, I'm taking 120 milligrams of oxycodone, and the morphine equivalent for that is 180 milligrams. So I'm taking 180 milligrams, and I'm supposed to be at 30 milligrams before I even put the patch on. And I'll tell you why in just a minute, why that's very important to do. The next thing I found at Dr. Google is that you are supposed to be in full-fledged withdrawal from the other opioid you're taking, in my case oxycodone, before you take buprenorphine or introduce buprenorphine into your system. So before I put this patch on, I needed to have not taken a dose of oxycodone for at least 12 to 24 hours. Well, he didn't say anything about that. Now, the reason that you need to do all this stuff to reduce the amount that you're taking to 30 milligrams and to be in withdrawal before you take it is that you go into what's called, if you don't do that, you go into what's called precipitated withdrawal. when you just quit taking the oxycodone, if I just went cold turkey and quit taking it, that's standard withdrawal. Precipitated withdrawal means that your withdrawal systems, it all happens in a very short period of time, which makes it much, much, much more intense and dangerous. Now, I know what precipitated withdrawal is like because I ended up doing it in a different situation later. But when I read all this, I thought, man, I don't want to go to this guy. There just wasn't anything good about this deal. So it's back to the primary care physician. But what I learned from that interaction was it's going to be hard for me to find another doctor because they're all going to have the DEA concern. And it turned out later, you'll hear from this story, that I was right. Finding another doctor is very difficult. So now I'm back to addressing the issue of trying to get my primary care physician to help me taper. Now, let me say this before we go any further. It is the responsibility of the physician who prescribes oxycodone or any opioid to help the patient taper off of it. This is from, and that's the advice from every medical entity out there. This is from the Mayo Clinic. It's just one example of responsible opioid response by a physician prescribing it. When it's time for you to stop taking opioids, ask your healthcare professionals' help. Together, you can create a plan to stop opioids slowly called a taper. And then down below, it says you may need weeks, months, or even longer to slowly and safely lower your dose and stop taking your opioid medicine. You're much more likely to succeed if you partner with your healthcare team. Well, that's what I wanted to do. Here's another example from the FDA. Healthcare professionals should not abruptly discontinue opioids in a patient who is dependent, physically dependent. Now, that doesn't mean disordered. There's a difference between being dependent and being addicted, just to make that clear. And the FDA goes on to say, create a patient-specific plan to gradually taper the dose of the opioid and ensure ongoing monitoring and support as needed to avoid serious withdrawal symptoms. I could go on and on with examples of healthcare entities saying that it is the responsibility of the physician who prescribed opioids to help the patient taper off of it. So in between the time that I saw the pain clinic doctor and when I sent this email, I had sent another email that I don't have a copy of to my primary care physician saying, I have a taper plan. Would you support me in that? And his reply was he would if it was a reasonable plan. Now, I had a full bottle of oxycodone I had just filled when I got that crazy email from him. So I worked out a plan on how to use that bottle to taper. And here I'm talking to him about that. This is an email I sent after going to that crazy pain clinic. When I told you I'm tapering off oxycodone and asked for your support in that, you said you would support me if it was a reasonable plan. I hope you think my plan is a reasonable plan. It would require no more than 2 more prescriptions and maybe just 1. And then I say, I'm on my 6th day of my first taper. I went from 30 milligrams to 25 milligrams, which is a 17% drop. Now remember, CDC and FDA and all, they suggest a 10% drop. The recommendation of CDC and every other place now is to go 10% a month or a week if possible. I'm almost doubling that, and it's been okay. What I mean is I'm not suffering too much from the withdrawal. The last hour before a dose is no fun, but I can handle it without disturbing Pat. At 17%, I'm almost doubling the universal recommendation. My plan is to drop 5 milligrams per taper. If I can do it weekly, that's 5 weeks of tapering. However, because of Pat's surgery next week, I'm looking at 6 weeks. My wife was going to have major abdominal surgery, and I didn't need to be in withdrawals while I was dealing with helping her with that surgery and its immediate aftermath. So I was giving myself a week off on the taper because of that. I haven't sat down to figure it out, but I had my last refill May 24th and started the taper May 27th. So I'll be taking 25 instead of 30 for 2 weeks, followed by 20, etc. As I said, I would think 1 more, maybe 2 more prescriptions would be all I need. I wanted to be on 20 milligrams when I meet with you next week. However, I have a problem because of Pat's surgery on Monday. And that would make the taper 6 weeks, I say. And then I tell him the pain clinic doctor's solution was to prescribe a 15 microgram, and I say whatever, I wasn't sure if that's what the term was, Butrans patch, and said if I went on that, then he could prescribe oxycodone as needed at a lower amount. I want to be off the opioids, not on buprenorphine for life. And I'm going to talk a lot more about buprenorphine in the third video. The only other solution I have is to go cold turkey. Really, I might rather do that, but Pat would be unimaginably disturbed by 3 days of that, and given my other conditions, my health conditions, I'm afraid it may not be safe. I can't go around to other doctors asking them to help me taper off this. That's what I figured out after talking to the pain doctor. I don't think I'm going to find one. Obviously, I would be having the appearance of a disordered addict. I will be seeing you next week, but it would really be helpful to hear you reiterate your willingness to support me through this process. As I said, I'm terrified by the prospect of cold turkey, both for myself and for Pat. Well, here's the response I got. I'm sorry if this is not in keeping with your ideas. Remember the nature of his emails and our relationship before I sent him the email reporting on the Valium trial. Now he says, I'm sorry if this is very cold. I'm sorry if this is not in keeping with your ideas. While I do indeed appreciate your idea of tapering and discontinuing opioids, I do not intend to follow our previous pattern. What the heck was that? Our previous pattern was I was always telling him what I would do, and he's always approving it. It was never even an iota of an indication that there was some problem with our previous pattern. Nor do I intend to follow your logarithm. How cold is that? The logarithm, my taper plan. Then he tells me that this daytime drug treatment program is where I need to go to support my goal. And he recommended I contact this daytime drug treatment program. Okay, so now he thinks I'm disordered and I need treatment? Where did this come from? So I replied to that email and I wrote, it is certainly true that I wrongly changed the prescription without talking to you first. Now remember, the way I changed it was to take less than he prescribed, but I wanted to be solicitous because I didn't think I could find another doctor, and I was hoping at some point he would come to his senses and help me taper off this medication. So I was just trying to do what I could to be as positive as I could be. So I say, I should have talked to you first before I took half of what you prescribed. I did not keep secrets and never have. You know what I did because I told you. And again, I took less Valium than you prescribed, not more. Well, I understand your irritation with my experimenting on my own, although I don't. I don't understand how taking less of the Valium than prescribed is disordered. Because I presume that you still intend to have me as a patient, I need to let you know what I plan to do. I'm going back to my original taper plan, dropping 5 milligrams a week. I have more than enough tablets left to do that, even if I pause for a week for Pat's surgery. I had finally figured that out. That means the percentage of the taper will increase steadily, 20% to 25% to 50%. Remember, the recommendation is 10%. So I'm really doing an aggressive taper here. If I was addicted to oxycodone as opposed to being dependent, I would go straight to, and I said the treatment center, he said. If it wasn't for the pandemic and Pat's disorder, I would go even though I'm not addicted just to follow your suggestion. I mean, I would have just done what he wanted just to be compliant. But I go on to say there is no way possible I can go to that treatment center during the day and come home to Pat, possibly infecting her with a deadly disease. That is simply not a choice that I have. And then I go on to describe my wife's medical conditions. She is having a severe struggle. There is no way that I can go and sit around a bunch of people all day and come home to her. It's just not possible. As my doctor, it's important that you can trust me. Once I get done with this taper, I would like to continue to have a urine test or some sort of regular basis until you're satisfied that I'm not a disordered addict. Well, here's a reply I got. Ed, I am not convinced that you have behaved in a disordered manner. The matter of your pain management has become labor-intensive. Level of complexity between what Dr. and the neurosurgeon has tried to accomplish, and what we have tried to do in terms of medication and what you feel the need to do physically seem to not work in a reasonable congruence. I do not believe that she, and he means you, have behaved in a disordered manner. So he wants me to go to a treatment center, but I'm not disordered. And somehow between the time he very cheerfully prescribed Valium and I reported on that, this level of complexity has come up. Y'all, something happened between the time he did the Valium and when I reported on the trial. I don't know. Something happened. So I'm in a desperate situation. I need to find some way to come off this medication that this doctor has prescribed without risking a bad outcome from withdrawal and without endangering my wife in her 70s by exposing her to a deadly virus. And then I remembered a friend from the past who could help me. And then, not her fault, things got really worse and bizarre. And we're going to tell you about that in the fourth video in this series. Hope to see you then.